53%, and actually the disease-free survival was also improved from 76 to 85%. It's about a 45% improvement, and that was statistically significant. Whereas the CLGB trial that also looked at the addition of platinums and also bevacizumab to anthracyclines and taxanes in triple-negative breast cancer showed the same results in terms of achieving a PCR. PCR rate with the addition of platinums was improved from 41% to 54%. However, the disease-free survival was not different. So you achieved a higher PCR by adding the platinums, but your disease-free survival did not improve. So these two results contradict each other. And then furthermore, another study that was just reported just a few months ago, this summer during ASCO, looking at, in addition, adding to anthracyclines and taxanes, platinum or platinum plus a PARP inhibitor, veliparib, in triple-negative breast cancer. This is a phase 3 study in the neoadjuvant setting. And again, just to skip to the results because I'm really running out of time. Here we have the PCR and the rate of clinical response. So compared to conventional taxane and anthracycline, adding platinum and veliparib improved the PCR significantly, but you can see that actually the benefit mainly comes from the platinum. The addition of the PARP inhibitor was not effective, unlike in patients with BRCA mutations. So again, what I said during my previous talk, PARP inhibitors are most probably not that much effective in triple negative, but mostly in BRCA positive patients. So in the neoadjuvant setting for the platinums, what we can say is the role right now is not very well known. It increases PCR rate, but the long-term disease-free and overall survival benefit is not known. So what we do in the clinic is we discuss the pros and cons and discuss the side effects and decide with that. But then I need to mention that there are neoadjuvant studies looking at platinum regimens. The NeoSTAP study, the Cadence study are ongoing, so hopefully we'll have results. One important aspect is there a role for extended therapy in the neoadjuvant setting? And treating patients in a neoadjuvant setting, if they have residual disease, actually offers a nice opportunity to study agents. For example, the CREATE-X study is a randomized phase 3 study looking in HER2 negative patients, looking at capecitabine versus placebo. And this study showed in the triple-negative subgroup that in patients with triple-negative breast cancer who did not achieve a PCR, doing 8 cycles of capecitabine improved disease-free survival and overall survival. And based on this data, several clinicians discussed the use of capecitabine in this patient population. And again, there are other studies going on looking at genomically directed therapy, immunomodulatory agents, pembro in patients with residual disease, and vaccine strategies. So for future directions, I don't have to mention that triple-negative breast cancer is a heterogeneous disease. Studies are going on with platinums, PARP inhibitors, immunomodulation, AKT/PI3 kinase inhibitors, and even SRC inhibitors with dasatinib, and also androgen receptor blockers. So in conclusion, we still have to work a lot on making progress in the treatment of triple-negative breast cancer. It's responsive to chemotherapy, but the long-term outcome is still not excellent. Doing neoadjuvant chemotherapies for triple-negative breast cancer not only helps us assessing the in vivo activity of new drugs, but it also helps us identifying patients who have residual disease, and then we can study extended adjuvant therapy. Of course, it's very challenging because triple-negative breast cancer is a very heterogeneous disease, and right now in the neoadjuvant setting, we are lumping them all together, but it's going to be very difficult to sort out the data. With this, I think I'm finishing almost on time. Thank you very much.
Thank you so much, Banu. Just one quick question, which I think is very, very important for all of us, if you could clarify. So in triple-negative breast cancer, PT1A tumors, the absolute improvement in long-term outcomes is in the range of 4.6%, but the p-value was 0.14. In PT1B, it moves from 91.9 to 97.1,
right,
which is 5.2%. So 4.6 PT1A, 5.2 PT1B. And now the recommendations are no chemo for PT1A, recommended for PT1B. So my question, and I would like you to clarify if you don't mind, do you really think that we should not offer chemotherapy for PT1A with an absolute improvement of 4.6%?
I think when you look at the risk of recurrence and the absolute benefit, it's actually less than 4% for T1As. And none of the studies are prospective. So, and then what you're quoting is one of the positive studies, but then there are also the 2 negative studies. So it's very hard to make a decision. Personally, I would have a very hard time offering chemo to a 3 millimeter, patient. With 5, we are stretching it. And everyone is different, but I think we treat more between 5, after 5, but before that, I think it's very difficult. Now for HER2 positive disease, for 3 millimeters, high grade, some people offer Herceptin and weekly Taxol, for example.
Thank
but
you so much.
no prospective
Sorry for
data.
the interruption, but I think I wanted to clarify this. Thank you so much.
Sure.
So now it's my pleasure to introduce Dr. Sajak.